When individual units hesitate within a narrow channel, they cluster. That localized friction rapidly scales up to clog the entire system. In modern healthcare, that friction takes the form of pre-consultation uncertainty. Within orthopedic pathways specifically, large volumes of patients arrive to discuss knee and hip osteoarthritis without a clear understanding of their disease stage or their treatment options. Standard, unstructured clinical consultations frequently fail to resolve this decisional conflict. Patients leave the clinic as undecided as they entered, trapping them in continuous, nonlinear feedback loops of recurring appointments and delayed care. Administrators face a precise tension here. They must resolve this bottleneck to restore pathway flow, but they must do so without inappropriately restricting access to care or pushing patients into specific treatments. Resolving patient indecision at the micro level, inside the individual consultation, is the only sustainable mechanism to restore flow at a system-wide scale. Torbay charts is a visual shared decision-making tool utilized directly during standard consultations. It provides a structured map of the patient's disease stage alongside the corresponding evidence-based options. To measure its true impact, we are examining an expanded multi-site validation dataset. This moves past initial pilot data to test the tool's performance over extended time periods and across varying clinical environments. This combined evidence base now scales to exactly 216 detailed patient responses, evaluated alongside 55 distinct clinician evaluations. The analytical objective of this dataset is straightforward: determine if a localized visual aid produces statistically reliable, reproducible changes in overall surgical demand. Any behavioral shift proven by this dataset must simultaneously align with established clinical safety standards to be viable for system-wide adoption. We begin by analyzing the foundational metric of any clinical tool: patient-reported decision quality. This radar chart maps the 4 core shared decision-making domains from the evaluation cohort. The composite average reaches 4.38 out of 5. The highest performing domain is patients feeling involved and heard during the process, scoring 4.43 out of 5. The qualitative narrative feedback attached to these scores explains the mechanism behind them. The dominant theme across patient comments is visual comprehension. Patients repeatedly note that seeing a physical map of their disease stage clarified their current reality, with one stating it was helpful to actually see the position that I am in rather than just being told. This clarity led directly to behavioral activation. Patients understood their active role in the care plan, noting next steps like, "Now I know I need to strengthen and go to the gym." Achieving consistently high patient-reported experience metrics confirms that the tool prioritizes individualized, structured care over simple cost-cutting. We can track the actual decisional journey of these patients from their expectations before the consultation to their final choices afterward. This Sankey diagram maps 46 patients' starting positions, 25 completely undecided, 11 expected surgery, and 10 non-surgical. Following the consultation, 23 of the 25 undecided patients flowed into clear decision paths. Only 2 remained undecided. The use of the tool is associated with a 92% resolution rate of pre-consultation uncertainty. Broadening the scope to the wider 216 patient dataset reveals a critical pattern within the subgroup who arrived expecting surgery, approximately 56 patients. Tracing this subgroup, 19 of those 56 opted against surgery after their consultation. That represents a 33.9% change in preference within the surgery expectant population. In strict governance terms, this is classified as a change in treatment preference, not a surgical diversion. The distinction matters. These patients were informed, not deflected. We must also address the inverse flow, patients moving from a non-operative expectation to choosing surgery. 0 patients in the latest cohort made this escalation. The intervention reliably resolves decisional conflict and shifts preferences without pushing patients toward unnecessary clinical pathways. The primary clinical safety objection to these metrics is straightforward. Does altering treatment preference inappropriately delay necessary surgical care for severe patients? To answer this, we utilize the Oxford score, an objective, standardized metric used to measure a patient's physical joint severity and function. This scatter plot charts final treatment choices against patients' mean Oxford scores. Distinct clusters form: 26.5 for non-surgical and 9.7 for surgical. The Pearson correlation coefficient between Oxford score and surgical choice sits at negative 0.83. The Oxford scale is inverse. Lower scores indicate much worse physical symptoms and severe loss of function. This strong negative correlation means the patients actively choosing surgery are overwhelmingly those presenting with the most severe symptoms. Conversely, the cohort choosing non-surgical management mathematically presents with higher scores and more manageable symptoms. This specific distribution is exactly what clinical administrators expect to see in a healthy, fully functioning pathway. This correlation proves clinical integrity. The tool mathematically aligns patient choices directly to objective disease severity. Validating individual clinical interactions allows us to extrapolate these proven microshifts into macroeconomic operational outcomes. Across the entire 216 patient dataset, the baseline rate of behavioral change is an 8.8% whole cohort shift to non-operative care. This grid represents a theoretical standard hospital trust managing 2,000 orthopedic patients per year. Applying the validated 8.8% whole cohort shift isolates exactly 176 units within the system. That yields exactly 176 fewer surgical conversions annually. Applying the £9,450 cost per surgery, this shift generates £1,663,200 in cost avoidance. Even projecting a highly conservative 2% systemic shift, it still results in £378,000 saved annually. Beyond direct capital, these reductions compound to release crucial operational capacity, freeing up pre-assessment clinics, outpatient slots, and theater time. Structured decisional clarity at the consultation level generates over £1.6 million in actionable system capacity for a single trust. We have tracked a localized visual aid verified across a reproducible 216-patient multi-site dataset. The mechanism driving these systemic results is the 92% resolution of pre-consultation uncertainty. The Oxford correlation provides the evidence that these shifts are clinically appropriate, ensuring that all patient decisions remain strictly severity aligned. This is a patient-centered decision aid. It operates completely distinctly from inappropriate cost-cutting diversion tactics, focusing solely on informed treatment preference. Empowering patients to visually understand their own disease state is the most clinically sound method to optimize elective recovery and eliminate pathway bottlenecks.